infants. It uses a technique called air displacement plethysmography. The instrument, in fact, there's only one commercial instrument available at this time. That instrument is called the Peapod. And the procedure, and you can see the first image up on the left, shows an infant being weighed. It takes a few seconds to do that. Then the infant is placed inside this chamber. Obviously, the chamber is closed to confine the volume. And before this measurement is done, there's a reference volume placed in the system so you can calibrate the system. And so then by looking at the difference between the volume of an empty chamber and the volume with the baby in it, you can calculate out the volume of the infant. Weight, so we now have weight and volume, so we can calculate density, and quickly we can get a measure of the percentage fat. Now the error on repeat measurements is on the order of about 1%, 4% fat, so it's quite accurate. And we've done enough studies over the years now to know that if the baby, for example, were to urinate in the chamber, you could take it out, you could clean it, remeasure them again, and you would get a change that would reflect that change in the urine content of the baby. Well, it's interesting, you have a different timer than I have up here. Okay, the results then are immediately available. That's a nice advantage of this system. And with the system, they give you a longitudinal growth charts based upon either the FOMA or the reference or the Butte models, where you can now plot out percentage fat versus age. This can be done for full-term infants, and they also have a similar plot for preterm infants. Now, the Peapod advantages, it's portable, it's on wheels. There's no body fluid samples to collect, which is a very nice feature. It's relatively easy to perform. It takes only a few minutes to make the measurements, so you can train. You don't have a highly technically trained person to perform the measurements. And then once you have the system, the consumable supplies are not needed, or no replacement of consumable supplies, such as when you do the urine, you have to have syringes and so on. And it can't be repeated as frequently as needed. Now, this is really an important issue because, again, in the water measurements, because of that technique, once you've given a tracer, you must wait a minimum of 10 to 20 days before you can repeat the procedure. This procedure you can repeat as frequently as you want, within days, hours, or whatever interest you may have. Now, the disadvantage is cost. It's not something that's that inexpensive. There's some issues about the environment that it's in. You need a clean environment, which translates meaning minimal dust and stable temperatures. It has to be, it's a piece of electronics. It needs to be in a good environment. And the other issue is you have to disconnect all monitors from the infant. So this becomes sometimes an issue when you have preterm infants, which are in the NIC units and often have many leads and monitors on the baby. And there's issues about hydration if it's abnormal, but that's also an issue with the total body water measurement. But the primary limitation is one of body size. And the maximum weight is in the range of 8 to 10 kilograms, which is approximately 8 months of age. Now, there is a pediatric option that can be used with the adult system, but this one only starts at age 2. So with this technology, there's a gap between, say, 6 months and age 2. That is something that's trying to be addressed that has not been resolved yet. There are now a number of studies that are appearing in the literature that are using this technique, and this just, for example, shows the percent fat range that one would observe in breastfed healthy term infants. These are measurements made at 1 month intervals. It's an international study. It was like 4 studies, 3 sites, 4 in the US, 2 in Europe. And again, you can see, and if you also analyze this, you would turn out statistically show that the girls across these age ranges tend to have a slightly higher percent fat than do the boys. Another technique is the dual energy X-ray absorptiometry technique. This is another technique that's used substantially, primarily for bone assessment, bone mineral density, or bone mineral content. The requirements is no movement. If there's movement during this procedure of the infant, the assay is inaccurate, invalid. You should not attempt to even to analyze it. So usually the infant has to be asleep, and oftentimes small infants are tightly swaddled to control this. Scan time is about 3 minutes. There is a small radiation exposure of about 10 microsieverts for this procedure. And the weight range is from 1.5 to about 13 kilos, which represents from birth to 12 to 15 months of age. This shows you the kind of image we would see. And the secondary use is if we look at that image on the left and look at the pixel locations that do not have the bone, they can be analyzed for the relative composition of the soft tissues and the non-bone pixels. And this will give us some idea of the percentage fat. That information then can be converted into measures of the total lean tissue mass and the fat mass. Now, the precisions here are very good for the bone measurements, order of 1 to 2% for BMD, 2 to 3% for BMC. Percent fat is typically 3 to 5% for the percent fat measurement. And if you look at the subcompartments of the lean and fat, there are 4 to 5 for lean and 8 to 12 for fat. Said another way, this instrument is really designed to measure bone. This is, again, secondary information. It's not the primary objective. One issue that we have not resolved is the fact now, if I do one baby, or same set of babies on the two different techniques, the Peapod or the DEXA, we get different results. And that the DEXA values tend to be higher than the Peapod. So this is an issue of absolute accuracy, which has to still be resolved. So the body composition mesh used in infants, we said there's water. It's used against all age groups. The Peapod has been used primarily in the birth and preterm infants, and the blue colored pluses indicate there's going to be substantially more of this kind of data appear in the next probably year. But we're limited by the older age groups. And DEXA can go across all the age groups, but because Peapod has come onto the scene, the use of DEXA for infant measurements has dwindled substantially because of this issue of the fact that Peapod is so much easier to do. Now, the methods that would represent or best used for field studies are the total body water measurements of the stable isotopes, because you can go out in the field, collect samples, and bring them back to a lab. The other two instruments are really not as portable to be taken into the field. Now, normally I would stop there, but I want to show you one more method which is not that commonly known, which is called K40 counting. Now, this was done in the 60s, and it was discontinued somewhat because of the complication of the technique. And that is related to the fact in the 60s, it's like, think about the phone you had in the 60s, think about the phones you have today. Same thing in this nuclear spectroscopy electronics. The electronics we have today is so much improved over what it was 40 years, 50 years ago, that this technique is now being reconsidered. And the reason why it is being reconsidered is done by what's called whole body counting. It is interesting that it is a natural radioactive tracer. Every one of us has a small fraction of our potassium is radioactive, and we can detect that. We can observe that and measure that as the gamma rays are emitted from the human body. The reason why there's so much interest in this now is this starts to define the quality of the fat-free mass. In particular, it's focused at the protein mass. And again, through a series of assumptions, we can convert that potassium number to a protein number, but it's more commonly used what's called body cell mass or muscle mass, so the more common measurements. In my center, we have been using this technique for a number of years. This shows an example of about 1,000 infants, term infants. We looked at them at different ethnic groups. There are differences between boys and girls. There are differences within ethnic groups or among ethnic groups as well. But using these data, we have developed what's called LMS modeling. That's the Tim Cole approach to how do you determine centile rankings. And the multicolored lines that you see going from the left to the right represent the centile rankings within a normal term infant population. The data I'm showing you here is for preterm infants. So we're monitoring the change over time with the preterm infants. This issue about catch-up growth. When do they get back? Not based on weight now, but based upon the lean tissue mass or the protein mass. When does that start to become more normal? This shows that kind of the same type of data, but now where the potassium is converted to a body cell number, and in turn that has been converted to a z-score value. And this shows you the longitudinal changes that we can observe in infants. The two dashed lines represent our 10 to 90th percentile for normal, and each of the connected dots of the different colors show the change in the z-score for the lean body mass as a function of age for these preterm infants. As you can see, some infants start to, within about 30, 40 weeks of age, start to get back within the normal range and will stay there, but there are still a number of infants, one infant in particular, I can see that takes it almost 60 weeks to even get within the normal range, but yet we still see 3 or to 4 infants that even after 60 weeks of age, they still have not gotten back into the normal range. So we're now looking at how does this relate to the history. In other words, for example, did they have infections or the change in the diet? What are the issues that are making these kinds of differences? So in summary, then, body composition assessments, body composition assays now have sufficient precision to establish the range of normal variations observed in healthy growth during early life. We can now establish these centile curves. What's the future outlook? Well, at present, the focus has been mainly on monitoring changes in percent fat. There's several reasons for that, but one of the obvious reasons is the technology. If I'm using water, or if I'm using Peapod, all I can measure is fat, and therefore there's been a large focus in that direction. Plus, as we know in adults, the whole issue now about obesity, all the cardiovascular disease had been related to fatness. And so there's that underlying assumption that what's going on in adults what is the same thing that's going on in infants. That may or may not be true. We really can't say for sure. What I do think you'll see in not too distant future, at least for things like the Peapod, you'll start to see what we call body composition growth charts. And again, these will be initially for percent fat. These are the same as weight and height growth charts, but now they're going to be based upon fat, a body composition parameter. And these may help us to better refine the use of the anthropometric-based indices, such as BMI or weight for age and such. But also, an understanding of the concurrent changes in the lean tissue we believe will be important. And this is why we undertook this approach, to get that separate measurement of the lean tissue mass, because we don't think it's just fat, we think it's a combination of relative changes in the two. In those first 2 years is what is predicting the outcome. So with that, I'll stop and thank you for allowing me to give this presentation.